Good morning, everyone, and welcome to relink.org's webinar on It Takes a Village and More, Babies Exposed to Opioids and How We Can Help. My name is Barbara Campbell, and I am the Executive Director of the Dalton Foundation. We are a foundation located here in Northeast Ohio that supports a lot of programs and projects in the area of addiction recovery, re-entry and second chance employment, and healthcare. The relink.org project is one we have supported for a long time. Relink.org is a faith-based nonprofit statewide organization started in 2017 with the desire to use technology to connect those in Ohio that are looking for resources for addiction recovery, re-entry, and we've even expanded it to human trafficking. It's an online free-to-use database that has over 7,200 resources in it across the state of Ohio. And we encourage everyone to log on to relink.org and check that out and use that to help people locate services. Today, I'll be helping to just facilitate this webinar. We have some wonderful speakers, and I'm going to turn it over to them as fast as I can because the content is amazing. There are a lot of you joining today, and we do encourage you to type any questions in the Q&A section or the chat section. We will be monitoring those today and getting to as many questions as we can. If we don't get to your question by the end of the time, we will connect you directly with each physician and have them follow up with you. So again, and then if you have any technical issues, again, please type that in the chat or send me an email at bcampbell@relink.org, and I will get that and try to help you. But I humbly admit I'm not the most tech savvy person on the planet. We've got two speakers with us today, and what I'm going to do is I'm going to introduce both of them, and then I'm going to turn it over to Dr. Groh to start. And then when she finishes, we'll switch over to Dr. Lynn. So we're very pleased to welcome Dr. Groh with us today. Dr. Groh is a native of Akron. She attended Northeast Ohio Medical University BSMD program with Akron University, and then completed her residency in pediatrics at Akron Children's Hospital. She left for a fellowship training at the University of Michigan and returned to Akron Children's in 2002 to practice neonatology. She currently is a professor of pediatrics with Northeast Ohio Medical University. She has focused her work in several areas of quality, including neonatal abstinence syndrome, therapeutic hypothermia, breast milk and breastfeeding, neonatal outcomes, and neonatal respiratory processes. So Dr. Groh, I want to turn it over to you, and I will pull up your slides. Okay, Dr. Groh.
Good morning, everyone. We are going to talk about the role of how opioids affect a baby, how this affects us as a community, and the steps that we've taken through the years and some current things that we're working on. Really to emphasize for today, the point is not to make us experts, but to realize that this has been an ongoing issue for not just a few of us, but all of us. And it's going to take all of us to work through and moving us all forward together as a community. Next slide. So what is NAS? Next. It is actually a composite of clinical findings. Sometimes it's called neonatal abstinence syndrome. Sometimes it's called neonatal withdrawal. But what happens is a baby is exposed in the womb, and up to half of them or so or more will actually show signs of withdrawal afterwards, after they're born. About a little less than 2/3 may require medical treatment, and most of their symptoms may occur within the first 3 days, but sometimes it can even be delayed as far as a week. Next slide. And opiate withdrawal is very complex, and there's a lot of issues that can be made make it even more complex. For instance, if mom's on other medications, either street or prescribed drugs, antidepressants, benzodiazepines, they can have their own separate withdrawal syndrome. And what makes it hard for those that are caring for these infants and moms is there are not a lot of processes and treatments if a baby is going through a tobacco withdrawal or a benzodiazepine withdrawal or antidepressants. So it becomes, a lot of things become intertwined, and the only one treatment we have is for those with opiates. But neonatal abstinence syndrome withdrawal severity can also depend on how it affects the baby, how it adapts to its life after it's born. It can affect their sleep, their breathing, and their basic autonomic functions of their life. Next slide. It's very complex. It's a constellation of signs and symptoms of withdrawal. It involves their muscle tone and their movements, their breathing ability, their ability to digest, and difficulty with feedings, and neurologic symptoms. And it's very variable. Infants can have different symptoms over different time, different intensities, and often I will explain this to families, it's the same as an adult. Two adults may have the same, you could have two adults that have very similar body types, very similar genetic makeups, and one might have a total different response to an opioid or an alcohol as far as how it affects someone. So the babies themselves, just like adults, can have a great variation in how this affects them. Next slide. This is an example of a slide just to kind of show, and from a medical standpoint, we put all their symptoms and signs that they're having in two big categories, more of a neurologic and then those of GI disruption. So from a neurologic standpoint, they may have tremors, they may not wake they may be too awake, too alert, not sleep well. They may have exaggerated reflexes, seizures, sneezing, yawning, all those tie into their neurologic symptom. And they may have feeding issues. They may want to suck, but not be very coordinated, trying their best to eat, but then not be very efficient. They can have vomiting, diarrhea, poor weight gain. Their nasal symptoms can affect their ability to feed because babies are obligate nose breathers. They can get fevers, they can get mottled, they can get too hot, they can get too cold. A lot of these tie into the GI dysfunction as well. And this all stems to the fact that our bodies have these opioid receptors all throughout our system, and the neurologic and GI functions have a lot of opiate receptors that get coated with the opioids while the baby is in the womb. Then you take away those opioids and there's an effect on the receptors that affects these body systems. Next slide. And there is great varioclinical presentation in all the things that can affect it, whether it's the type of opioid used, mom's personal drug history, her smoking history, when did mom take the medication or drug before delivery, how does she metabolize it, how does it get crossed over the placenta, how the placenta metabolizes it, the baby's metabolism. There's so many factors that really come into play to add to the variation for all these infants. Next slide. So when we're assessing a baby with neonatal abstinence, the problem is we don't know exactly when's the best time to evaluate the babies, and some of it is due to the poor understanding of how this really works. Through the years, the medical community have come up with varying scoring scales that have been developed. And the purpose, though, even though there's different scoring systems, is to have a systematic approach, to be objective, to do it periodically and a consistently a way to evaluate the baby, to really see what their medical needs are and if they need medication. Many institutions have had different scaling systems and taken scales and processes out there and even modified them to be then their own system. So there is not one standardized process for how to evaluate the babies and treat them. Next slide.
Sorry, it's not working. Hold on.
It's okay. I have a paper copy with me, and I can keep talking.
I'll get you back up. Just give me a second. Apologize, everybody.
All right, let me find my paper version of where we left off, and I will keep us talking while she finds our slides. So the next one would be slide 9. And this is just an example of one of the scoring systems. And I put this up just to show the kinds of things that we're looking for with a numeric approach to the process. And it looks at things like tremors, irritability, reflexes. Do they have normal poops, or are they more explosive like diarrhea, and for how long? Do they get so irritated that they'll kind of irritate their skin by rubbing their knees and elbows into their mattress? Do they have trouble breathing and sneezing and yawning? And this is just one example of a scoring system. I haven't used it as much, but some institutions find it very helpful because it's fairly simple, put together in the mid-70s, early 80s. One scoring system that we had used in Akron used way more than this. I can't even remember how many different points it had, but it was almost twice as complex as this one, a version of a Finnegan score, but there's probably 20 versions out in the world of what a Finnegan score is. But this is just an example showing that you're looking at different issues of the baby and the scores and giving them a numeric value. Next slide.
I'm going to try to get it back up to the big section, but
that's okay. And we use the scoring system to help us decide if we need to give medical treatment. But the next slide shows us things that are non-medical. And any of you that may have had children can value that sometimes a baby just needs snugged and swallowed and swayed and sung to. And we've learned through the years that a lot of the non-medical things are very helpful for these infants. They like a gentle touch. They like a darker environment, quiet talk, holding, snuggling, good containment within blankets and swaddling, gentle rocking, gentle assisting when they're going from a sleeping state to a wake state, or when we're changing their diapers or getting them ready to feed. Not quick transitions, but very slow, gentle. It helps them go through those initial periods when they're either being evaluated for treatment or at risk for needing treatment based on their early, based on their delivery in early days of life. The one thing I notice that we medically run into is sometimes we leave a room so dark, so long, they're getting ready to go home and we haven't adjusted. So I like to encourage our staff that as a baby starts a healing path, that we be a little bit more louder and a little bit more bright in the room and a little bit more normal activity, so that by the time they're going home, they've already adjusted to a, quote, real world, and they haven't lived solely and entirely in the dark up until now. Next slide. Maybe next slides. Yeah.
Next one.
Yeah. So opiates not just affect the baby, they affect the mother. The moms have a 70% chance of having an unwanted pregnancy. Moms that are on opioids have a 90% chance of using tobacco, a 60% chance of psychiatric illness. More than 50% are involved in a version of sex trade. They have a higher use of IV drug use with incidences of hepatitis B and C. And they have a lot of history of childhood traumatic events. And as a fetus, if a mom smokes, they're at risk for preterm birth, stillbirth, low birth weight. The babies also are at risk for perinatal transmission of infections. The babies, if the mom has been on certain medications, that can also affect the baby, including risk for death and SIDS. We have learned through the years that treating a mom who's on opioids is way better than not treating her. And I'll get to more to that later. Next slide. This is just a nice little colored picture of showing in a medical format what happens. And what happens is our body has opioid receptors. They're used to living in a sea of opioids and narcotics. And then that gets abruptly taken away when the cord gets cut. And so the baby's bloodstream doesn't see that opioids anymore. The receptors don't see it. And this is just an example of how all the different chemical surges occur because the opioids are had a quick abruption of what they have not been seeing. So their corticotropins increase, dopamine, acetylcholines, noradrenaline, serotonin decreases. These are chemicals that our body naturally has that get elevated because the body isn't getting what it's needing. So when we treat a baby, if they need treatment, we give them very low doses of an opioid so that we basically, as I call it, we coat the receptors, and that we gently take a few away at a time, and it stops some of these chemical cascades within the body. Next slide. We also know through the years that there's a longer term effect on these babies. These are various studies that have been done through the years to look at babies who are on different kinds of opiates, what they were exposed to, some of them medications, some of them street drugs, but they have found consistently that babies that have these exposures to the opiates can have difficulty later in life with developmental problems, cognitive problems, language, motor, developmental behavior. And the problem that we run into, at least locally, is the volume of these infants is so great, it's hard to put them all automatically in a system. So we really encourage our general pediatricians to be very cognizant of the development of the child. We do have a great system to get them enrolled into development assistance if needed. And the local services like Help Me Grow and community services are very helpful in assisting these patients and families through those early years. And I highly encourage our moms to really take an active role in using those services. Next slide. So how big is this a problem? How did we get here, and how does this affect our moms? Next slide. The next slide this is one of my favorite slides, and it took me for a bit when I came across this. Morphine has been isolated with us since the early 1800s. It's been over 200 years. We have actually had morphine within our system. And when we first recognized that when it came into commercial production where people could go get it and use it, was at the time when John Quincy Adams was our president and John Marshall was our Chief Justice. So we've been in this morphine business for a very long time as the United States. We only had 24 states in our country. And then when we finally actually started to recognize there were problems of neonatal withdrawal, it actually was in 1875 when we had Ulysses Grant as our president. Now, they did discover that there was a problem with neonates and opioids, but that first case of 1875 really wasn't discovered until 1935. They just went back and looked at things. But this is a very nice slide showing you that morphine's been around for a long time, heroin's been around for a long time, hypodermic needles were even before the Civil War, and we have all these issues. And then we decided, in 2012, there was an epidemic. I don't think there was an epidemic in 2012. I think we had been working up to it for all these years. But this really took me for a little bit of a shock when I saw this and how it came to be for us in the United States. Next slide. And we as a medical community realized in the late 90s we didn't treat cancer pain very well. We brought it to the forefront, and it became an actual requirement for hospitals to pay attention to pain, to count it even as a fifth vital sign. Well, what did that do for us? Next slide. We started writing more narcotic prescriptions, and this is an example in Ohio. In the 80s, 90s, when I was in school, we heard all about the crack cocaine babies and the crack cocaine babies. But look at all these prescriptions we've been writing since 2000 for opioids, prescriptions, not street drugs. So we've been really using a lot of narcotics. Next slide. This shows in the early part of 2000 how many moms were using opiates around their births. That shot up about 5 to 6 times across the country. Next slide. And babies that were exposed around the time of their birth and concern of true having neonatal withdrawal or NAS shot up from about 1.2 to 3.4. So about 2 to 3 times as much of NAS just in a 10-year period across America. Next slide. This shows how we've actually had a lot of drug overdose deaths. Heroin has been pretty consistent through the years. Interestingly, cocaine has increased as well, but look at the opioid analgesics, that top line. These are unintentional drug overdose deaths since 1999 for the first 8 years in the 2000th decade. Most of these are unintentional deaths, and over half of them are involving prescribed pharmaceuticals, which is now why a lot of our community fire departments, police departments actually have access to Narcan, so that if they come across someone who they think is in an overdose situation, they can give them a quick reversal to save their life. Next slide. This also shows how, as a nation, our opioid use has increased for our deliveries per 1,000 deliveries. Since the early 2000s, it's gone up sixfold in about 15 years. And this is just using 28 states. They didn't even have all states available for this data. Next slide. So this has affected us as a nation. These babies stay in the hospital for about 12 days, up from a 2 to 3 day stay, and the costs are costing us 5 to 6 times that of a normal birth. So as we start to look in Ohio a little more specifically, next slide, we can see that our drug overdose in Ohio residents, many are multi-drug, but then after that it's opioids, and 2/3 of the opioid overdose drugs are with prescription medications. It's not as much heroin, methadone, street drugs, and things they're getting off the street. 2/3 of our opioid drug overdoses are from prescriptions. Next slide. This is a nice chart showing that for 12 years, our use of our drug overdose deaths increasing. We have more deaths and we have more drug overdose deaths. So very much a direct correlation. Next slide. And this is a chart comparing car vehicle traffic accidents, which is in blue, and suicide rate, which is in green, and unintentional drug poisonings in the beginning of the 2000 decade, and how our unintentional drug poisonings have been rapidly climbing as far as in comparison to the others at the beginning of the year. So car accidents, suicides being pretty static, but our unintentional drug poisoning deaths have really increased at the beginning of this century, decade, whatever you want to call it, millennium. Next slide. So we've had a 4 times increase in unintentional drug overdose, a 5-time increase in opioid distribution. Next slide. Pregnant women, about 5% are predicted when they're if they're pregnant, they're about 5% are predicted to be illicit drug users. They still often will use marijuana and cocaine, but we are not very good at recognizing prenatal drug use. Next slide. And we know specifically that about 1 of every 3 women of a productive age will fill an opioid prescription. About 7% of women will self-report the use of opioid pain medication, and 1 in 5 of those that self-report that they use prescription opioids state that they are getting them for a non-healthcare source, or they're using it for something other than a reason other than pain. Next slide. Smoking in pregnancy is very common, 20 to 40%. And if you are a mom that is a smoking pregnant woman, you are 4 times as likely to use an opioid as opposed to a woman who is not smoking. Next slide. So we do know that self-reported tobacco use is an indicator of illicit drug use. Roughly 6 times you're more likely to be a drug user from this evaluation that they did. Self-reported alcohol use also is an indicator of illicit drug use. These are babies that are more likely to be preterm and low birth weight. And if you were to test all of the population, you might have at least 20% of them with at least 1 substance use at delivery. There are some delivering institutions that will do that, check every mom as they come through the door. That is expensive. And sometimes those tests aren't available till after the child would have been discharged. So we don't typically do that at our local hospitals. Next slide. This is just showing that if you have prenatal drug exposure, that those babies are 3 times to be preterm, low birth weight, and have feeding and breathing trouble still. Next slide. So we do have, it is an objective that if a mom is pregnant, to put her through a maintenance therapy during her pregnancy. And the rationale is that if we put moms that are on opioids, even if it's street or prescription drugs, but put them in a program, we can reduce any illicit use, we can reduce criminal activity, other culture things that come in with drugs, decrease our smoking, and incorporate medication use for moms that might be in drug therapy with actually prenatal care that both together can decrease obstetric complications. Next slide. So there's a lot of different programs. Some of them dispense it daily, some weekly. There's a package of care that comes with that. And the doses, the OBs either do that or work with specific addiction specialists to help with this. Next slide. So what have we done locally? Next slide. We were involved with 6 children's hospitals in Ohio to try to help and decrease this issue with the babies. Governor Kasich recognized this was a problem and gave us a grant to try to improve things. Next slide. And the reason he saw this is as of 2014, for every 10,000 births, we actually had about 135 babies with NAS. That's statewide, but locally, we pretty much were twice that rate in the Akron area. Next slide. This is an impact that for financially to the state of Ohio, because in 2 years' time, our finances spent on these newborns jumped by $30 million, and the hospital stays increased by 6,000 days. So this is rapidly taking form of difficulty for the state of Ohio, because many of these moms are either non-paying or end up in the Medicaid system. So this is very much a societal problem. Next slide. This is just to show you that there's a lot of babies across the state, different counties being affected, and the state is paying attention. This is as late as 2018. In Summit County, we had 87 babies born to have NAS in Summit County. Franklin had 242. This is another slide just showing you that the state of Ohio is paying attention. They pay attention to what kind of babies they have, how many days of length of stay. It's slowly gone up from 3.4 to 3.8. They still are babies that are having trouble with their medical outcomes as far as feeding and low birth weight. I wanted you to see this just so you could see that they are paying attention in Ohio. Next slide. And in the summary, what that means is even as late as 2018, babies had 2.5 times, almost 3 times increased risk of having feeding difficulties, almost twice as likely to have a low birth weight, almost twice as likely to have breathing trouble, and almost 4 times as likely to have seizures. Next slide. So through the years, next slide, what we've done at Akron, next slide, we have a new unit, but the nice thing I wanted you to see about this unit is on the lower left side, we have private rooms. It used to be we had a pod unit. We had these babies in an open room that didn't give moms privacy. They now can have privacy. They can spend time with their baby a little bit more and really bond with their baby. Next slide. This is just to show you that since 2009 in Akron, we've been working before people even recognized that this was a problem. We've had a couple different changes in treatment programs, 2009 to 2013. In 2011, we started a 3-year work with our OB group and the community agencies to work on it from that angle. Then we're involved with the governor on his grant to improve outcomes. We've tweaked that through the years, and we've enhanced our education to our nurses and really focusing now on how to enhance our non-pharmacological treatment and improve our scoring system and decrease our use for medication. Next slide. So we can go to the next slide. So the next slide will, I wanted to talk about what we did in 2014 with our local groups is we worked with our OBs. We've realized since through the years, we can't change our demographic data. We can make things better so that babies are less likely to need treatment, less likely to need morphine and medication, and really try to improve them on as best as we can, but we've even made better changes since this. Keep going. Next slide. We have learned we need to be consistent with our education for our staff, use our tools and electronic charting as best as possible, and not rely on our memory. Next slide. This is just to show you in the 5 units in Akron a couple years ago that we had in one given year 181 babies at an average daily cost of $66,000 per patient, staying about a little bit more than 2 weeks. So it's been a lot for these babies to have to go through this. Next slide. So a village piece of this, next slide, came in 2014 when we worked with our community center and our OBs to really see what do the OBs know. What are they doing to help these moms? How can we help get these moms the help they need before they deliver and make it a better place for everybody? So next slide. We asked our babies and we asked our OBs, what would you do if a mom came into you and said she needed some help or had some concerns with substance use? Next slide. And they said, oh, we give them this card, this street card, and these are all the things that they can do and go and get to. And that was overwhelming for us. And we thought, well, if we don't even have this as an issue as a medical care provider, this was confusing to us. So we tried to go through working with our OB teams, working with the community, looking at the street card. What did these moms have to go through before delivery? Next slide. And this is just one of 3 pages. It took us 3 pages to map out what goes on. And we thought, there is no way that anyone can reasonably think through this. Very hard if you're an OB provider, very hard if you're the mom, very hard if you're a community agency trying to help mom. No wonder there was a lot of chaos in Akron on getting these moms the help they needed. Next slide. So we took on and simplified it to 1 page on what they should do. If you have certain medications, you call this number. If it's a different kind of medication, you call this number. And really trying to help triage people on who got what help they needed when they were pregnant. Next slide. So next slide. We put together a packet, but went to the OBs, we hand delivered them, and we gave them information on what the OB should be needed to know for substance use, where they could help these moms and refer them to, what to do. But we also gave them information of what the moms could actually have themselves. Next slide. So we came up with even information handouts that the OBs could give the moms and we gave things for the OB so they wouldn't have to do the work, and gave them instructions that the moms could have on keeping their appointments, what they expect at the time of delivery. And so we gave handouts for the OBs and handouts for the moms and said, free reign, go copy, make as many copies as you want, put whatever of your stickers and your design you want on it, go for it. Next slide. We also gave them detailed information about narcotic withdrawal for babies. Next slide. As well as recommended obstetrical guidelines for treating and screening moms for these problems. Next slide. Another screening tool, the 4 Ps. Next slide. And we ended it with just the basic things of what to do when it ends. Make sure you try to screen your moms one way or another. Don't be afraid to referral. Please don't be judgmental, be encouraging, be honest, discuss things through the Care of Mom's course, encourage her to continue with ongoing addiction support and breastfeeding, and how to talk about delaying the next pregnancy so the mom would have time to heal. Next slide. So even in Ohio, years later, we still have trouble with increased length of stay, Medicaid patients being, for most of these infants, and 7 times the number of discharges that we even had 10 years ago. So we're still having a lot of these infants. Next slide. But we haven't given up hope, and a lot in the state of Ohio have come up with something called the MOMS program. Next slide. And this is a very detailed practice on how to help the moms get their medication, get enrolled for services, wraparound care to help with mom and fetal outcomes and family stability, and also cut the costs towards the state of Ohio. Next slide. So the people in Ohio that put together this program include all these departments and agencies that you may not typically work together. It involves Medicaid, mental health, human services, jobs and services, as well as medical universities and healthcare specialists and community agencies. Next slide. So this is just the cover of their care model. It just shows you that all the phases of their obstetrical care are put together in this package of care. Next slide. So for us, next slide, the latest two things we've done, we made our scoring tool 3 items. Do you eat? Do you sleep? And can we console you? We give you a scoring system. The nurses work together. Next slide. You either get a score of 1, 2, or 3, and that depends on whether you get treatment or not. We keep it very simple. Next slide. We've made our protocol very easy on whether they need to give medication or just reassess and rescore. Next slide. And this is what we've come up with, that since we've started this, our average number of morphine doses in a baby before they went home was around 90, and now it's just averaging just about 1 to 2 before they go home. Next slide. And their length of stay was averaging around 21 days, and now we've gotten it down to about 12. So they spend a lot of time snuggling and cuddling and not needing medication and getting home sooner. Next slide. And our goal for 2021 is a new process called recovery coaches. Recovery coaches are used more in the adult world for addiction in a process so that if someone wants help to walk through their recovery, they have someone who is trained to help them with walking through those steps, someone they can reach out to, someone who understands what they're going through. We've realized there's not a lot of that for the moms in our state. So we're working with an agency to come up with a program for recovery coaches for moms that will have the specific recovery coach training. We will educate them a little more on narcotic withdrawal for infants and what the moms have to go through. And we're doing it as a pilot to see if we can help these moms phase from pregnancy and delivery to ongoing care and treatment in a way that may not be currently established in formal agencies, but in a way to help moms where there's gaps in those current aspects of care. So as we move forward, we ask that people continue to be mindful that this affects all of us as a society. We have a lot of us that are touched by this. It does not mean that we are bad people. We all have issues in life, and sometimes we figure them out at different phases, and we ask that we all work together to help out the moms move on towards healing, recovery, and breaking those cycles. That's all.
Thank you so much, Dr. Groh. I really especially loved how you have reached out to the community in the It Takes a Village model and got the OBGYNs involved to create awareness and trying to help the moms. I think that's going to be a perfect segue into Dr. Lynn's portion. And I really love those last few slides that show the impact you're having with all the non-pharmacologic treatments that you're working on. That's really wonderful. And I shared with them, I'm a mother of twins that were born 3 months premature, and a lot of this just brings home all the things we did with my babies and how they worked. And so anyway, I just appreciate all that you guys do. Thank you so much, Dr. Groh, for sharing. I'm going to stop my share, Dr. Lynn. While I introduce you, you can see if you can get yours to pull up. And if not, we'll definitely go on to Plan B. But without further ado, I want to introduce Dr. Lynn. She is a senior IT project scientist at the Research Information Solutions and Innovation Division at the Nationwide Children's Hospital. She completed her PhD in molecular medicine from the University of Auckland and Master of Public Health in Biomedical Informatics from The Ohio State University. As a digital health scientist, Dr. Lynn is interested in developing innovative technology-based solutions to address unmet health needs and improve healthcare delivery. Over the past 3 years, she has worked on a number of projects focused on addressing the opioid crisis. Her team recently developed a smartphone application for peripartum women with opioid use disorders. And this application won 2 phases of a grand challenge by and is currently in the finalist phase. And I think they just presented yesterday. So we definitely wish you the best of luck in that contest. And Dr. Lin, I will turn it over to you.
Thank you so much, Barbara. Thank you for the introduction, and thank you everyone for the opportunity for me to present our project here and share with you what we've done. As if I can share, okay. As Barbara has already mentioned, this project really stemmed out from a grant challenge posted by the Health Resources and Service Administration, Maternal and Child Health Bureau. And they are looking for innovative technology-based solution to improve the access to quality health care for pregnant and new mothers struggling with opioid use disorders. They're hoping that the solution can help to increase access to substance use disorder treatment, recovery support, and other support services for these women and their family. So I want to just kind of bring you into this process, how we kind of built out this project. So this project started back in early 2019. The challenge was announced at the end of 2018. So we had just kind of over 2 years to work on this project. Initially, we started with the literature research on the current publications, as well as kind of market research to understand the current solution that are available for this particular target population. And then we did a number of stakeholder interviews across both with the women themselves as well as the care providers. So this includes social workers, clinicians, pediatricians, nurses, recovery coaches. And with their feedback, we were able to validate some of the hypotheses that what can be built into this solution. And interestingly, one of the things that we did not think of was the high priority that they put into having the necessary resources, basic resources that can support them. So with that in mind, we had the opportunity when we talked with our collaborators at OSU, we got introduced to relinks.org and to know about the great resources they have around not just only the recovery resources, but also the basic needs that can really support the comprehensive needs of these women and their families. So we reached out to Barbara, and so we had the opportunity to work with them to kind of utilizing some of that resources from Relink and to bring that into this development. So this year, we built and tested our application. We first built it in Android, and right now it is being tested at the OSU STEP clinic, which I'll mention in a little bit later. And then we did the evaluation with the actual users that can test them. And then finally, we're looking at the dissemination step to know how we can introduce this to a wider population that can really benefit. So I want to show you just a quick demo of this app, not the whole thing, but just to kind of get you some sense of what it does. So we really try to build this out into a application that can empower the women to take care of themselves. And so we build this with the population in mind, kind of seeing them how that can be a path towards recovery if we can enable them to take actions. So we are very sensitive to the privacy issue. So we want to make sure it's a secure platform. So we're building it with ways that can secure their data as well as offline resources. We try to make it as a simple and intuitive interface that they can find the resources with a click of a button. They can actually add it to their calendar so that they can, even if it's outside of their service hours for these services that they've located, which we've been told is often the time that when they want to take action, it may not be the right moment for them to contact those, but then, things get easily missed and they may not be having that opportunity to follow up. So I want to really build this into the app, is trying to help them to take little steps every day towards recovery and better health and well-being for their babies. So we're building a lot of nice educational content, similar to what Dr. Groh has already mentioned. So we curate this content from a lot of public health agency databases, as well as collect them from our clinical expert, both from the OB/GYN that takes care for them, and also the pediatrician. So when you talk about these resources, it talks about pregnancy and addiction, the medication-assisted therapy. There's a lot of questions around what to expect, especially when the baby comes. So we really try to make this content available to them in an easy to digest manner. So we condense them, we check with our clinician for accuracy as well as for clarity. We also try to make it more accessible by having this audio option, so that it's not limited by literacy reading level, and so they can hear most of this content. We also want to be mindful of this, the potential trauma, as Dr. Groh mentioned, that can impact on their recovery. And so we're building contents around trauma, around wellness, and things that they can do and readily have that in their hand when they're ready to take that next step into take that action. And baby care tips, lactation, and NIS explained are some of the really nice resources that our current user testing group have informed that has really helped them to better take care of their babies. So even what Dr. Groh has mentioned, the Eat Sleep Console, we mentioned what that is. We mentioned about what they can expect at delivery and how they can take some of those non-pharmacological approaches home as well. So some of the tips that they can help to take care of their baby. We made videos of how they can do the swaddle, how they can do massage therapy. So we did this in collaboration with our pediatrician and our massage therapy group. So I'm just going to quickly show you that we really want to make sure this is not something that is just looks good or that we feel is useful. We really want to test its usefulness and ease of use. So we did this evaluation study at the STEP clinic. We're taking care of this woman, both providing the recovery support as well as prenatal care. And so these pregnant and new moms are supporting us in the 6-week longitudinal study. They asked to download the app and use it for 6 weeks, and we asked them at the end of throughout the study actually, and the end of the study, how that their experience of using this app. So just quickly to show that we did note that they have a high desire to download. So 80% of the eligible participants downloaded the app and willing to try it out for that period of time. They found that it's easy to set up, and they were comfortable with the data security measure taken by our group. These are just some of the feedback. So they were very positive in terms of how these can actually meet the needs of in terms of taking care of themselves, getting access, and some of them even mentioned how that has helped them to keep clinical appointments, and mention about how it teaches them about lactation, which was very helpful. And so it's has been very promising, even though it's a small scale pilot testing. And we can actually see on the back end in terms of what resources they have open, they have access that throughout the app, they were able to utilize a lot of these contents. So these are just some of the feedback from our user. And I also want to point it out, we also have presented to the clinician and the social workers that are caring for them. And I think they also are very enthusiastic and very excited to introduce this to the patients. And we're, especially this social worker, I think she was very excited that she no longer has to hand out too many papers, and she could just use this as a tool to engage with the woman that she cares for. With that, I want to just quickly introduce, I think Barbara mentioned that many people probably are unaware of this clinic at OSU. So we have a clinic that we partner with, the Substance Abuse and Prevention Clinic at the OSU. So they are providing the comprehensive care to pregnant women who are using substance, but they can receive both the medication-assisted therapy as well as group counseling and prenatal checkup, all at that same appointment. So this is a nice resource if you want to introduce to people that may benefit from this. So we're proposing how you can use this. You can actually use this in individual and group education settings. Our clinical advisor did mention that she find it would be very useful, especially for the low resource areas. A lot of providers may not have the ability to provide a comprehensive education, but you can introduce this app and for the woman to take, to be able to be informed on their own, or you can actually conduct a group session with them using the contents provided here. The clinical nurses have used it to set up appointment reminders for this woman, as well as the social worker and recovery coaches can co-plan their recovery goals, and then can save it and check it later. So these are just some of the ways that you might actually find this to be useful. And so what we are looking for is partnership. So we are hoping now that we kind of build this out and test it, we are now hoping to bring it to the next level. So we would like to see if we can partner with some of the community organizations or health agencies that are interested and bring this to your community. So if you are interested, feel free to reach out to me and I can do a more in-depth demo to you, and we can discuss about the opportunities that we can to really bring benefits to help our moms and our babies. So thank you. And this obviously it takes a village to build a solution. So I want to thank our really nice collaborators, both the development team at Nationwide, our pediatricians and our clinicians at OSU, as well as Relink, who really provided the very important basic resource data for to be implemented in this app. Thank you.
Thank you so much, Dr. Lin. You can stop sharing your screen, then I'll put up a different screen. And I encourage everyone, we do have, I know, about 8 more minutes left for question and answer. We do have one question I definitely want to ask. And if you have any others, please type those into the chat or the Q&A section. We'll get those answered. And one question that has been asked a couple times about sharing, yes, we will. You can get connected with either doctor to ask questions and get resources for sure. We will do a follow-up where we'll send out the recording of this as well. So please, everybody, know that. I'm going to see if I can share my screen real quickly.
So Barbara, do you want us to just respond to these questions that we see?
Yeah, I know the first question there was regarding Dr. Groh's presentation of how can they learn more about the recovery coach for moms. I think that's an excellent question. Dr. Groh, would you care to answer that one?
I will tell you, it's still very much in the infancy of the pilot. We're hoping that the pilot gets into flourishing the first quarter of 2021. However, if there, the Catholic Charities has been doing this in the adult world for a while. So if you, and they partner with United Way and Summa Health for that program. So I did check that the Catholic Charities on their website does have a way that you can reach out to them if you want to help them or just learn more. They do have even volunteer opportunities or ways to reach out to them to assist them in their process. I'll probably have more next year and details on how it goes, but we're very excited about it to get going.
All right, thank you. I was looking for additional questions. Are there any additional questions that have come in? Yes, there are. Here's one for you, Dr. Lynn. Will the Empower app have local resources to other areas, example, Summit, Stark, or Portage counties?
So we are providing the local resources through Relink. So I think Relink has coverage over those counties. Right now, we currently in our prototype, we build in resources for 12 counties near Franklin, the central Columbus area, because that's where we pilot. But that's one of the things I mentioned with partnership. I think knowing what the different community desire this product, we can then make sure that we bring in those resources and build in the local resources for people who want to pilot it.
Yeah, thank you. And I'll just mention a little bit about our partnership with Dr. Lynn and this Empower Care app, just because it is available to everyone. With relink.org being available for so many years now, we do have a lot of data in the database, both the data that you see publicly, which is about resources throughout Ohio, but also there's a lot of back-end data that shows a lot of where services are, where services aren't. We can identify what things are being searched the most, what organizations are being searched the most. So I say all that because we are, as the app, as relink.org has been developed now, we are now in a different phase of sharing this information with other organizations to help their work. I think Dr. Lynn's project is an example where we provided them some service data for Franklin County, but that's certainly available. You know, our goal, this is all public information. We're just putting it in one place and being able to let people use that in their apps. So I just want to let people know that that option is available and you can contact me about that. So I think it's a good way to just, again, our goal is to just connect people with the help they need as quickly as possible. And whether that's through relink.org or somebody else's app or somebody else's project, we're totally fine with that. So we're looking for that. Here's a question for you, Dr. Groh. Can you expand on breastfeeding and the provision of breast milk for a baby with neonatal abstinence syndrome?
Yes, I think we've learned through the years that we've always known that breast milk is very helpful. But what we've learned through the years as well is it might help mom in many ways in the recovery. Just the act of breastfeeding, the skin-to-skin touch, the milk that's made specifically for the baby in relationship to the mom, those factors alone will help in the neurosensory development and healing of the infant, as well as the GI disruption that they often may have in regards to feeding. Through the years, people have been very wary of medications and things going through the milk. The truth of it is, whatever medications or substances mom had, a lot of times you may have more of it when you're pregnant than after you've delivered. It is a national recommendation that certain illicit drugs or moms that are not in a program not be using a lot of breast milk, at least until they're on a program. So we've locally very much encouraged our moms to be in programs and to provide breast milk. And it does seem to be a very beneficial piece to a lot of their care.
All right, thank you, Dr. Groh. We do have a couple minutes left and we have 3 questions left, and I do want to get to those 3 questions. Yeah, we encourage you all to stay for just a few more minutes. We might go a couple minutes past 11, but if you do have to hop off, know we will be sending out a recording and some resources, and we definitely thank everyone for joining us this morning. Here is one of our last of the 3 questions. Do you connect mothers with harm reduction services such as Narcan, fentanyl testing strips, or syringe services? I guess Dr. Lynn, maybe you first, and then Dr. Groh can maybe see what happened at Akron Children's regarding that.
So, sorry, the question is with harm reduction services?
Yes.
Right now, I'm not aware of that connection from our group, but I do believe that maybe through the STEP clinic, They have social worker and case workers that do provide that connection. So unfortunately, I cannot speak too much into what it's been done on the SDH neonatology end. So I apologize for that, but maybe Dr. Groh can speak about that.
As far as I'm aware, we don't specifically provide those. However, our social workers might be able to assist moms. And I think our main focus is really getting moms into programs for healing and therapy. And then whatever needs to be done in that realm, we have that be in their domain. There's a lot of moms that really need a lot of help. And we've noticed through the years that moms with babies hasn't been a primary focus for our society. So we're really trying to counteract that with what we already have in our systems. And that's where recovery coach is coming in, because that kind of idea came out of the adult world and adult addiction, and how we can roll that into mom-baby package and really incorporate what's already out there into moving it through. So we highly recommend that our moms be involved with treatment programs, and encourage them that not every treatment program is for everyone. And so you might have failed at one a couple months ago, but there are these 3 others you might like to try. And so maybe someone else might have a better success with you and help you out. So we don't particularly give out those things. We let that fall into the world of the addiction and healing specialists.
Okay, thank you. Yeah. Here's another question. Where can we go from here with disparities, gaps in services, and a real need for follow-up coaches or people that will coach people?
So that's what we're trying to do. I think that's what everyone across the state is trying to do. Like in the state, when they put together the moms program, realizing a way to help the moms in the beginning of their pregnancy, to keep them through the pregnancy and beyond the pregnancy with the services that we have available, easily accessible, not to where they have to try to figure it out on their own. Because I think the state realizes that we as a community have a vested interest in making these moms better, healing them, having the children raised up and healing them. And the hard part is there's only so many hours in a day and only so many resources available, but we're trying to really pull with what we already have. And that's where I'm very excited with recovery coaches and the recovery coach program. The hope is that this can be an added piece that can help the moms, because it doesn't matter who you are, being a new mom is stressful. If you're, it doesn't matter who you are, if you're trying to go through your recovery, it's stressful. But the connecting the two is, to me, very multi-complex, because in the world of recovery, you're supposed to spend time with yourself, work on your own personal healing. How do you do that with a newborn baby? Our programs are not set up for that. So we really need to think outside the box, do things differently, pull and tug from other established programs, and develop things that are new that can really carry these moms from point A to point B. Toronto has an excellent program that the moment within 24, 48 hours, these moms deliver, they are moved to another institution with their baby, and the entire wraparound services are done right there, and they stay as long as they need to carry that through. Our United States healthcare isn't set up with that, but we can maybe take the concept of wraparound services, the concept of giving everybody a way to kind of get them from point A to point B, and take what we have and try to expand and move it further. We're really hoping that if the recovery coach program works well, we can expand this across the state and even across the nation as a nice bridge to help in the medical healthcare system that really isn't set up for maternal addiction and help, but take what we have and expand and build it further.
Great, thank you. That is encouraging. I like this next question. Oh, go ahead, Dr. Lin.
Can I just chime in? And that is one thing that we did notice, is that there's some disparity, and also kind of our resources are spread thin. And I think that's where some of the technology solutions, and that's why this grand challenge can kind of try to meet some of those needs. It will not replace, obviously, the connection with actual human resources, especially our clinicians, but it can fill in some of that gap in between, and also try to reach out to those who are not seeking care with yet because of stigma, because of fear of losing their child, because of the the policy. So I think one of the ways that we're trying to assess is that this can actually provide some of the resources in between and encourage them to know where to look for support, as well as this can help with the more rural region where there's low resources, that they still get some of this really nice content at their fingertips and in a way that they can access.
Great. Yes. Thank you so much. This next question is interesting because I think it's important because it involves the family, and I think it addresses this topic you just shared, Dr. Groh, of how difficult this is for mothers alone. What about the fathers? What about men? Is there any plans to incorporate men, to incorporate the fathers to promote family?
We have always wanted to incorporate the fathers and family, and we've and every family is different, and every definition of family is different, and so we always encourage that when we have a baby and a mom, that if they have other caregivers that are assisting them, helping them out, to incorporate them. We never want to assume that the dads are going to be a part of the picture, because we also can't assume that every family is the same. But we've always encouraged moms to have their support. Who are their support systems? Pre-COVID, bring them into the unit, have them learn the same baby skills that you're going to learn. We've always encouraged families to put the time together to learn, especially if mom's going to need help after the baby leaves the hospital, even just to something simple with feeding, and so that mom can go to some appointments. So we've always really encouraged to have as many helpers for mom that she has, whether it's a neighbor, a nanny, the dad, her sister, to really get so that mom has a system as she leaves, not necessarily on her own. Sometimes those moms don't have that infrastructure and system, but we've always encouraged moms to bring in others to help and assist, especially if they need it through this time.
All right, and then here's our last question, and this one, Dr. Lynn, would probably be for you, and you may not know this, we may have to check with the OSU program, but the question is, do you know, does the OSU STEP program follow the mom's model of care?
I'm not sure, so I can probably put you in touch, and I can find out from our clinician at OSU STEP Clinic.
Okay, well, great. I can help translate some of these other questions, and there's been some requests for sharing some of the resources with organizations. Dr. Groh and Dr. Lynn, I'll get that with you so we can make sure we get that to people, that additional people that were maybe not on the webinar today. So again, I thank everyone for being with us. I encourage you to participate, and there'll be a quick, very short follow-up survey following this webinar. It helps us on topics and helps us do better in the future. So please take just a minute to fill that out. And once again, Dr. Groh, Dr. Lynn, excellent presentations. Thank you so much for your time today. And again, thank you to everyone for being here. Thank you for joining us today.
Thank you.
Thank you, Barbara. Thank you, everyone.
Bye.
Bye-bye, everybody.